Hi and welcome. Let's look at uterine prolapse with associated anterior vaginal wall prolapse, also known as a cystocele. Uterine prolapse is a downward descent of the uterus due to weakness of pelvic floor support, while cystocele is the herniation of the bladder into the anterior vaginal wall. They frequently coexist because both result from failure of the same pelvic support structures, that's the endopelvic fascia and levator-ani muscle, to give proper support to pelvic organs. Here you can see a normal vaginal orifice, while here you can see the uterus, the cervix to be precise, protruding via the vaginal orifice, which is known as uterine prolapse. In this picture, you can see a cystocele. Here, this is the bladder protruding out of the vaginal orifice. So, the cervix and uterus are seen protruding outside the vaginal introitus due to failure of pelvic floor support structures. That's the pelvic fascia, uterosacral and cardinal ligaments, and levator-ani muscles. This condition is common in multiparous women, that's women who have given birth many times, and postmenopausal women. So here you can see the normal structures of the pelvic, see the uterus in its normal position, the bladder, as well as the vagina. In this diagram, you can see the uterus protruding via the vagina orifice. Is now in the vagina instead of being in the upper part of the pelvic cavity. So a cystocele is commonly associated with a uterine prolapse. So let's look at the etiologies/risk factors. Multiparity, especially vaginal deliveries. Here, women who have given birth many times and via the vagina. Prolonged or obstructed labor, postmenopausal estrogen deficiency, chronic raised intra-abdominal pressure, especially in chronic cough and constipation, aging, pelvic floor trauma, obesity, and previous pelvic surgery. So let's look at the clinical features. Symptoms of uterine prolapse are sensation of something coming down via the vagina, vaginal mass, pelvic heaviness, low back ache, dyspareunia, that's pain during sexual intercourse. So what are the symptoms of a cystocele? Here we have urinary frequency, stress urinary incontinence, incomplete bladder emptying, recurrent urinary tract infections, and need to digitally reduce prolapse to void. So what are the complications if left untreated? Recurrent urinary tract infections, hydronephrosis in severe cases, that's retention of urine in the kidneys, sexual dysfunction, ulceration of prolapsed tissue, and urinary retention. So here we'll be looking at some questions, MCQs to be precise, on uterine prolapse. So A, the pathology demonstrated is commoner among women within the reproductive age group, which is false. Weakness of the broad ligaments leads to this pathology, which is also false. This condition may be associated with stress incontinence, which is true. The condition is readily amenable to pessary insertion, which is true. Corpus suspension is one of the surgical methods of correction, which is false. In the next slide, we shall be looking at why we have these answers. So, A, the pathology demonstrated is commoner among women within the reproductive age group, which is false. This is because pelvic organ prolapse is more common in older postmenopausal women, especially those with multiple vaginal deliveries. B, weakness of the broad ligaments leads to this pathology, which is false. This is because the main supports are the pelvic floor muscles, especially the levator-ani and uterosacral and cardinal ligaments, not the broad ligaments. See, this condition may be associated with stress incontinence, which is true because anterior vaginal wall prolapse, also known as cystocele, is commonly associated with stress urinary incontinence. D. The condition is readily amenable to pessary insertion, which is true because vaginal pessaries are an effective non-surgical management, especially in elderly patients or those unfit for surgery. E. Corpus suspension is one of the surgical methods of correction, which is false because corpus suspension is a surgery for stress urinary incontinence, not for uterine or vaginal prolapse. So, in a nutshell, pelvic organ prolapse results from pelvic floor weakness, commonly affects postmenopausal multiparous women, may coexist with stress incontinence, and is often managed initially with pessary insertion, with surgery reserved for selected cases. Thanks for listening. Do not forget to like, subscribe, and share if you found this video helpful.